Well, welcome, and thank you for joining us for today's symposium, Emerging Topics in Women's Health, Minding the Depression Gap, as part of VCU's Health of Women 2025 conference. I am Irina Ninye, Chief Science Officer of the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education, while promoting research on sex differences to optimize women's health. For more than 35 years, SWHR has led interdisciplinary groups of researchers, healthcare providers, patient advocates, and policy leaders to address diseases and conditions that disproportionately, differently, or exclusively affect women. For those of you who are active on social media, SWHR will be live tweeting during this event and invite you to join us by using the hashtag SWHR Talks Mental Health on all platforms. Sex differences in health and disease is a well-established truth. This table presents the leading causes of death in the United States in 2022, according to data from the Centers for Disease Control and Prevention. The conditions listed here are among the leading causes of death across the lifespan for females that have a higher percent of total death than males. For females under the age of 65, chronic obstructive pulmonary disease, or COPD, was disproportionately higher. And for females 65 and older, respiratory tract cancers of the lung and bronchus were higher, almost 2.8-fold for females compared to males. While not all diseases and death conditions, while not all diseases and health conditions result in death, many affect an individual's lifespan, resulting in morbidity, disability, and/or reduced quality of life. The data shown here from the Institute for Health Metrics and Evaluation presents disease burden as disability-adjusted life years, or DALYs. Notwithstanding drug use disorders, depressive disorders have a significantly high disease burden for reproductive age females, whereas COVID-19 and ischemic heart disease cause the greatest disease burden for older age females. To highlight the latest national and state data on diseases and health conditions that have a significant impact on women's health across the lifespan, SWHR launched its Women's Health Dashboard. This site allows you to explore public health data, research investment in progress, health insurance coverage, and relevant policy implications and actions. Launched with the data starting in 2018, SWHR is releasing new updates to reflect new focus areas that have emerged in their impact on women's health, including chronic liver disease and cirrhosis, COVID-19, and lung cancer. Depressive disorders was an original focus of the dashboard and remains a significant contributor to disease burden for women. Hence, today's symposium will discuss advancements in depression research and women's health care across the lifespan, with special emphasis on persistent depressive disorder, the intersection of depression and maternal health, depression during the menopause transition in older age. And our distinguished panelists will present strategies as to how research, clinical, and policy stakeholders can all work together to address persistent research gaps, disparities, and unmet needs for women living with depression. Between 2018 and 2021, the disease burden of depressive disorders increased by 34% among women ages 15 to 49 in the US. Depressive disorders are the sixth leading cause of disability in women worldwide. And in 2023, the Behavioral Risk Factor Surveillance System, or BRFSS, reported that 20% of women and 15% of men indicated having a current or past diagnosis of depression. Dr. Nitsan Gabel Ayel is currently pursuing her Master of Public Health degree at Johns Hopkins Bloomberg School of Public Health, with a focus on women and reproductive health. Her research and clinical experience span diagnostics innovation, fertility care, and cancer. Dr. Gabel Ayel has been actively involved in social impact initiatives, including providing mental health support for children and teenagers and promoting innovative approaches to primary care. She is passionate about leveraging her diverse experiences to tackle complex health challenges through research and policy solutions. Today, Dr. Gabel Ayel will walk us through some calls to action to address the disease burden of chronic forms of depression in women, for which she led the development during her Science Policy Fellowship at SWHR. The gender gap observed in depressive disorders notably emerges during adolescent ages. And while the cause of this disparity is unknown, there have been documented sex differences in the presentation of symptoms. For example, women experience somatic or emotional physical symptoms more than men, such as insomnia, fatigue, and changes in appetite. Additional impacts unique to women also occur during major hormone transitions, during life stages such as puberty, through menopause, and even older age. Dr. Lisa Galea is the Treliving Family Chair in Women's Mental Health and Senior Scientist at the Center for Addiction and Mental Health, as well as a professor of psychiatry at the University of Toronto. Dr. Galea is a world-renowned expert in sex hormone influences on brain and behavior in both health and disease states. Her research examines the effects of hormones, stress, and reproductive experience on neuroplasticity in females. This preclinical work is essential for developing tailored treatments for brain disease in both women and men. Dr. Galea developed the first rodent models for perinatal depression, and her research continues to reveal novel insight into the mechanisms by which pregnancy and motherhood impact risk in psychiatric disorders in the short term and the trajectory of cognitive aging in the longer term. She has published over 200 papers, and is the immediate past president of the Organization for the Study of Sex Differences. Dr. Galea will discuss how research could better think about sex-based approaches to depression with examples from her own work about minding the depression gap for women. After a certain age, every woman will have experienced menopause. Healthcare providers must be mindful of potential changes in emotional and mental health associated with the estrogen depletion during this particular life stage. During perimenopause, the diagnosis of a depressive disorder increases 2.5-fold for women. And according to the Impact Menopause study, 1/3 of menopausal women reported experiencing depressive symptoms. With less than 4% of women consulting a mental health provider about these symptoms, there is a need to address barriers to seeking and accessing the necessary care for their mental health. Camille Wilson is a dynamic senior executive with dual expertise in aging services leadership and women's health innovation, bringing unique insight to address critical gaps in women's midlife health support. Currently, she serves as Senior Vice President of New Affiliate Integration Services at AARP, while leading groundbreaking initiatives in menopause education and support as the founder of Claret Circle and CEO of Menopause Made Modern. She has also served on the board of directors for the Society to Improve Diagnosis in Medicine. Camille will present today about her personal menopause experience with depression and how it propelled her to live it out loud and engage in patient advocacy for women during this stage in their lives. Policy solutions that can properly address gaps in research on depressive disorders and unmet needs in women's mental health care require engagement of science, policy, and patient perspectives. Education and awareness about the scientific needs and discoveries, paired with patient stories and feedback, are crucial to developing evidence-based guidelines, accessible interventions, and inclusive healthcare policies. There are actions that anyone and everyone can take to advance women's health and promote legislative change in the mental health space. Unfortunately, too many potential stakeholders are unaware of the opportunities to enhance their bench, bedside, and boardroom work through advocacy efforts. Lindsay Miltenberger is a Chief Advocacy Officer at the Society for Women's Health Research, where she leads SWHR's policy agenda, building relationships with policymakers and key stakeholders to advance women's health. Lindsay drives efforts to raise the visibility of and promote the value of health services and systems research through government relations, communications, and advocacy. Among her many areas of focus are building and leading coalitions and partnerships to advance healthcare policy legislation for uterine health, heart health, obesity, and other underrecognized areas of women's health. Lindsay will discuss the current policy landscape for mental health and the role science plays in healthcare policy to close the depression gap for women. After our 4 presentations, live attendees will have the opportunity to engage in Q&A with the panel to discuss approaches to improve mental health and depression outcomes for women across the lifespan. So at this time, I'd like to welcome Dr. Gabel Ayel to kick us off with a call to action to address chronic forms of depression in women. Thanks for joining us, Nitsan.
Hi, let me just share thank you for the introduction. Let me just share my screen. Okay. So, hi everyone. I hope you can all hear me. My name is Nitzan Gabriel. I recently graduated medical school and I'm currently completing my MPH at Johns Hopkins University. I have been a science policy fellow at SWHR for the past few months. I've just finished my fellowship 2 weeks ago. And today I want to highlight the burden of chronic forms of depression in women. So, when we talk about depressive disorders, first we need to understand their definition. So the most common definition used is based on the DSM, which is the gold standard for mental illness diagnostic guidelines in the United States. And according to the most current version of the DSM-5, depressive disorders are a group of mood disorders characterized by significant impairments in an individual's ability to perform daily tasks. And this is driven by a persistently sad or irritable mood. And the emphasis here is the impairment in performing daily tasks. While there are several sub-diagnosis categories, the term depressive disorders typically refers to 2 entities. One is major depressive disorder, which is MDD, and persistent depressive disorder, PDD, unless otherwise specified. And these 2 disorders share many similar features, but there is a clear distinction in their diagnosis. So, which we'll go over in the next slide. Here we can see the diagnostic similarities between the 2 versus the distinctions. In a nutshell, the symptoms required for diagnosis are extremely similar between the 2. However, they differ by duration and number of criteria needed for diagnosis. MDD requires the daily presence of 5 diagnostic symptoms for a period of at least 2 weeks, while PDD requires less diagnostic symptoms, only 2, but for a much longer duration, for 2 years. An individual may be diagnosed with MDD, PDD, or both, depending on their symptom pattern. So the emphasis here is that they differ from each other, not by characteristics mostly, but by duration of symptoms, and thus they can be very heavily intertwined many times. When we try to estimate the burden of depressive disorders, our main measure of disease is the disability adjusted life years, DALY, where 1 DALY represents the loss of the equivalent of 1 year of full health. In 2021, depressive disorders were the 6th leading cause of DALYs in women globally, while in contrast, depressive disorders did not rank among the top 10 causes of DALYs in men. And the disease burden is particularly pronounced among younger women in the United States, ranking among the 3 leading causes of DALYs for women between the ages of 15 and 39, accounting for 10,246 DALYs per 100,000 women across this age group. And the disparity in depressive disorder prevalence between sexes has been consistently documented over the years. It is well established that over their lifetime, women experience depressive disorders at approximately twice the rate of men, with the gap emerging and being most prevalent during adolescence. Sex and gender differences have also been noted in variations in symptom presentation and comorbidities. Women are more likely to exhibit atypical and somatic symptoms, meaning emotional symptoms that manifest physically. For example, women with depression tend to experience more insomnia or hypersomnia, changes in appetite, and persistent fatigue. Women also tend to experience greater symptom severity compared to men, contributing to a higher overall disease burden. There is also a difference in comorbidity patterns between the sexes. While women are more likely to have higher rates of comorbid anxiety disorders, men have higher rates of comorbid substance use disorders. Despite these very well-documented sex and gender disparities in depressive disorders, there remains persistent gaps in our knowledge and approaches to mitigating the burden of these diseases for women. So for the next few slides, we're going to focus on gaps in the research and treatment of PDD in women and how we might overcome these. So the first gap we're going to talk about is the inconsistent use of definitions and characterizations of persistent depressive disorder in the literature. So PDD is actually a relatively new definition. It was introduced in 2013 in the latest DSM, the DSM-5 update, where they made some significant changes to diagnostic criteria, including the establishment of PDD as a new depressive disorder diagnosis. PDD consolidated two previously separate entities. So it consolidated dysthymia, which is a mild yet persistent form of depression, and chronic major depressive disorder, which is a severe form of major depressive disorder, defined as an extremely prolonged major depressive episode. Since the 2013 guidelines, there appears to be a lack of consistency in the way PDD is referred to in the literature. So the terms dysthymia, chronic depression, and episodic and recurrent depression are often used interchangeably or grouped together, even though they can be separate entities. This hinders efforts in building a foundation of knowledge to better understand the actual disease burden and potential treatments. Evidence suggests that chronic forms of depression, like PDD, lead to poor overall functional outcomes, higher rates of attempted suicides, and greater healthcare burden. When PDD is equated to dysthymia, which is largely viewed as a milder form of depression, and fails to recognize that PDD also encompasses a severe illness such as chronic MDD, misguided conceptions of PDD on personal well-being can lead to missed opportunities for interventions for hundreds of thousands of women who are disproportionately affected by PDD. So what could we do? We could promote research focused on the prevalence and burden of disease of PDD in the United States using updated DSM definitions. So since the DSM provides very clear diagnostic criteria and codes that can be reconstructed over time, efforts should be made to align previously collected data with current definitions, allowing for a more accurate assessment of PDD's true burden. This should be done continuously with regards to updated definitions. Also, one of the most important sources of global burden of disease data, which is hosted by the World Health Organization, still relies on the DSM-4 definition of depressive disorders. That definition categorizes depressive disorders into MDD and dysthymia and doesn't have the PDD entity. So this classification potentially underestimates the burden of chronic forms of depression. Apart from the literature, attention should also be paid to ensure congruency in ICD guidelines, which is an international system of medical coding, which is typically utilized in the United States for health data collection and insurance billing to round this all up. So another important gap that we noticed was while the disparity in depressive disorder prevalence between men and women is well established, there is still very limited understanding of sex differences in the course and outcomes of these disorders, particularly when we're considering PDD. So this lack of knowledge partially stems from a lack of sex-specific analysis in other aspects of PDD, such as severity measures and associated comorbidities, leaving additional gaps in our understanding of the disorder. As we mentioned, the notable sex gap in depression prevalence emerges during adolescence, and some researchers suggest that the activation of sex hormones during puberty influences future stress responses in adolescent girls, increasing their susceptibility to stress-related mood disorders, such as depression. Evidence also indicates that persistent depressive disorder, when it begins in adolescence, carries significant long-term health burden and is associated with poor adult mental health and occupational outcomes, especially in women. Persistent depression is linked to increased use of both inpatient and outpatient care in adulthood, as well as higher overall healthcare expenditures. Depression can also impact physical health. A 2018 study showed an inverse association between PDD and cognitive scores in middle-aged women, but it did not show the same association in men. Another study found an association between increased biomarkers of diabetes and recurrent MDD in women with a BMI equal or greater than 30, compared to their counterparts without recurrent MDD. No such association was observed in men. So these findings highlight the importance of further research on the effects of PDD on women's health. We suggest the promotion of a standardized sex analysis framework in future research exploring PDD and depression. We know that studies often fail to incorporate sex-based analysis, limiting our understanding of how biological, social, and environmental factors shape the course and outcomes of PDD. This oversight represents a missed opportunity to gain critical insights into diagnostic differences, treatment responses, and potential outcomes for women. Promoting a standardized sex analysis framework in PDD research can help drive more effective, evidence-based approaches to diagnosing, treating, and preventing PDD in diverse populations. We should also develop guidelines to screen for PDD in adolescents and in women. Current screening guidelines for depression that exist focus on assessing MDD and do not address chronic forms of depression. Due to its chronic nature, PDD takes longer to diagnose than other forms of depression. So the importance of this lies in improved outcomes. Early recognition of depression is known to improve disease trajectory and increase remission rates. So we think that broadening awareness among diverse healthcare providers, including OBGYN, primary care physician, as well as other women's health practitioners, would help establish a more robust opportunity for recognizing and documenting PDD patterns over time in female patients. This approach would also account for women's unique life stages and experiences, potentially leading to more effective, specific interventions. The final gap I'm going to talk about today is the insufficient link between the pathophysiology of PDD and clinical outcomes. So with advancements in genetic sequencing tools, recent years have seen significant progress in understanding the physiological and genetic profiles of depression. Some studies also identify genetic markers potentially associated with an increased risk of depressive disorders in women. Moreover, there are findings that suggest that the genetic burden in men with depressive disorder is higher than in women, indicating a potential alternative mechanism underlying women's susceptibility to the condition. However, these and other studies primarily focus on MDD, and most examine physiological factors that contribute to susceptibility rather than to differences in clinical presentation between men and women. Moreover, insights into sex-based differences in antidepressant metabolism have yet to translate into improved clinical efficacy. There are some evidence showing that SSRIs are more effective in premenopausal women and TCAs are more effective in men, but this was not translated into clinical efficacy yet. And it hasn't been replicated that well yet. As mental health illnesses are often stigmatized and many confuse emotional well-being and clinical depression, misconceptions about depressive disorders are common, with many assuming that depressed individuals can control their condition. This may be even more pronounced in PDD, where the depressive symptoms persist over extended periods. Establishing a clear physiological profile of depression would help combat these biases by providing concrete evidence of the biological changes associated with PDD. And so to bridge this gap, we could examine clinical differences in the course of disease, focusing on sex-based physiological profiles in PDD patients. As more sex-specific biological patterns emerge in characterizing PDD, we need to translate these findings into actionable clinical insights. However, many discoveries related to genetic, transcriptional, and neurobiological differences remain unreplicated, limiting their clinical application. So as the burden of PDD on women's health is explored, establishing a strong foundation for characterizing its sex-specific biological profile is essential. A deeper understanding of how sex-specific factors influence antidepressant efficacy, comorbidities, and disease trajectory will also enable more personalized treatment approaches, ultimately improving outcomes for both women and men. And so these were just a few of the gaps associated with the burden of chronic forms of depression in women. Thank you so much for listening. If you want to learn more about depressive disorders and how they affect women, you can always visit SWHR's Depressive Disorders dashboard. And you can see on the screen, there's a barcode. If you want to scan it, it will take you directly into the call to action itself on chronic forms of depression in women. Thank you for listening.
Thank you so much, Dr. Gabriel E.L. Next, we will have Dr. Galea, who will discuss the sex differences in mental health.
Well, hello, I'm delighted to be here to talk to you about one of my very favorite topics. Before I begin, I really think I should define what I mean by sex and gender. And by sex, I'm referring to the biological and physiological characteristics that may differ between females, males, and intersex individuals. While gender is not only gender identity, whether you identify as a woman, non binary, gender diverse, or man, but how society has expectations of you based on your gender identity. And I'm showing you pictures from my own family, and perhaps you can think that you can see some sex and gender differences. And you're probably very well aware that human females are more likely to live longer than human males, but you may not be aware that they're also more likely, and 25% spend 25% more of their time in chronic ill health than human males are. And this is my mother, who suffered from arthritis most of her life, as well as Parkinson's disease and endometrial cancer by the end of her life. I really appreciated this study. It came from the Danish registry that found for over 1,300 different disorders, human females were diagnosed on average 2 years later than human males were. And this was true for psychiatric disorders and neurodegenerative disorders. And now there are going to be many reasons for a delay in diagnosis, but one of the primary ones I believe is because most of our medical knowledge, including the way we diagnose people, has been because our medical research has been squarely focused on males and the experiences of men. So much so that symptoms are now referred to as atypical. And you see this atypical label across a wide variety of disorders, where there's a greater prevalence in males or a greater prevalence in females, or no sex difference in prevalence, suggesting to me there's a systemic bias. And words, of course, have consequences. They have consequences for funders, researchers, the people experiencing these symptoms, and even politicians. I think that this atypical label has been because we've used males. It's long been thought that males can be used as a standard or a default for females. But one of my take-home messages is that males can't serve as a default because we see too many differences. To me, it's like we're comparing apples to oranges. They're both fruit, but there's some essential differences. And when we're relying on that male standard, we get that atypical label, and we're using the wrong playbook. It's like trying to fix a refrigerator with an oven manual. Some things are going to be the same, some things are going to be completely different. And for me, it's not just about studying sex differences, but understanding that women's health needs some focus. So we already know that these female specific experiences can drive health outcomes and disease risks, including depression. And in my lab, we've been studying how estrogens affect brain health, as well as the short and long-term effects of pregnancy on brain health. Now, anytime you're looking at a disorder and coming up with clinical or preclinical models, it's really important to understand who's getting the disorder and when, because that's going to improve translation. And so it's often said that females are more than twice as likely to become depressed than men. I like this graph because it's the female to male ratio across the lifespan. And where you can see it comes above 2 is when you see higher levels of reproductive hormones in females, suggesting that they have a unique physiology that could result in these periods of susceptibility to depression across the lifespan. Now, I often get asked, well, don't men and women just show depression differently? To be diagnosed with depression, you have to have one of those 2 blue symptoms and then 5 out of the other 7 symptoms. And I think, if you're studying this area, that's a really good last name. And this is based on a number of door-to-door interviews as well as community samples. It wasn't until there was 5 or more symptoms that you started to see this flip in the ratio, showing more females than males. The other thing I want to point out is it's a very heterogeneous disorder. You can have insomnia or hypersomnia, weight gain, weight loss. There are many other symptoms that don't show up on this that are often comorbid with depression. And in fact, people have suggested there's 256 unique symptom combinations that can occur, making it a challenging disorder to model both preclinically and clinically. Now, are there sex differences in the symptoms of depression? Not that many papers out there, but as I've already suggested, there are atypical symptoms. There's more somatic symptoms, hyperinsomnia, hyperphagia, more rumination that's been observed in females compared to males. And it started getting me thinking, when we're using our scales, are we actually asking about these atypical symptoms? This paper looked at the 52 major symptoms of major depression, looked at the 7 common scales that are used, and found very little overlap between the scales. Now, this is a very complicated slide, but each of those colored dots, there's a solid color, it means they directly asked about the symptom. if it's an open circle, they alluded to that symptom. And I started to look at these female greater symptoms, and it turns out that not a lot of these scales are actually directly asking about this symptom. And it started to get me thinking that maybe we're not capturing as many females as we could be with some of these scales. What about biomarkers of depression? There are a number of them, including reductions in the volume of the hippocampus, increases in stress hormones, impairments in negative feedback, pro-inflammation, increased metabolism. Are there sex differences in some of these biomarkers? Well, yes, there are. I'm not going to list them all, but I'm just going to say a lot of studies don't look to see whether sex as a variable actually makes a difference in these biomarkers. And I really do think that's going to hamper our understanding. I'm going to give you a very clear example, which is looking at a number of different brain regions and looking at the transcriptome. And these researchers didn't find a lot of overlap in terms of the genes that were differentially expressed with major depressive disorder. And in fact, when there was an overlap, they found that the genes were expressed in opposing directions. So what are the common risk factors for major depressive disorder? Female sex is one of the biggest ones, and also chronic illness. And then a variety of other factors like family history and things that I would sort of group together as chronic stress. And in fact, in my own lab, we look at the intersection between chronic stress and female sex. And of course, we use a lot of preclinical models in my own lab. And I'm sure many of you are very suspicious of using an animal model for such a heterogeneous human disorder. But there, we can absolutely look at a number of the endophenotypes of depression. And I put the common ones we use up there. So we look at this interaction between female sex and chronic stress and a variety of these female specific factors. And I'm just going to touch on a few of them. Now, I already showed you this graph, and what this graph suggests is that ovarian hormones are more likely to confer risk for depression. But when you look at what are the times of greatest risk to develop first-time depression in a person's lifetime, it happens to be during the postpartum. And that's where you see these very high levels, then plummeting to hypogonadal levels. And also secondarily during the perimenopause, where you also see a drop in particularly estradiol levels. So are ovarian hormones conferring a risk or a resilience? And I will say that the jury is still a little bit out on this. I would say that there's more evidence for perhaps resilience and these transitions that are causing this greater risk for a depression. So some of the greatest data that I think what we have out there is coming from Viva Foyk-Jager's lab, where she suppressed ovarian hormones using a GnRH agonist. And this increased depressive symptoms, not depression itself, but depression symptoms. This was directly related to how much estradiol was reduced as a result of that treatment. It was also related to hippocampal volume loss, as well as changes to functional connectivity, including decreases in functional connectivity to the hippocampus and increases to the amygdala. Now, we've been looking at various models in rodents, and this is the work of Dr. Rand Eade, and she overoptimized or kept animals as shams in that perimenopausal period, and then gave them 6 weeks of chronic unpredictable stress to look at various endophenotypes of depression. And this is a busy graph, but it's some of the clearest data I think we have. So the overoptimized groups, that's those with eliminated ovarian hormones, are in green, pale green. And we saw this increase in passive coping. We saw more anhedonia, sucrose anhedonia. We saw more anxiety-like behavior. And we even saw signatures on the HPA or hypothalamic pituitary adrenal axis. So those endocrine signatures. We saw impairments in negative feedback. So overall, what I think this suggests is that withdrawal from ovarian hormones using a variety of models can increase depressive-like endophenotypes in both human females and rodents, suggesting that ovarian hormones provide resilience. Now, Rand didn't want to stop there. She wanted to see if she could give estradiol, could she prevent, and then give stress, could she prevent the depressive-like endophenotype? And she didn't just give estradiol, she also gave estrogen receptor agonists, either for alpha or beta, and looked at a variety of endophenotypes. I know this is also a little bit of a busy slide, but what she found was that overoptimizing these mice resulted in more of a depressive-like endophenotype. And estradiol, when she gave estradiol in blue there, it reduced that, as well as any of the estrogen receptor agonists, which is what we could have expected to find. But this was only true in non-stress conditions. Under stress conditions, there was no alleviation with any of those estrogens or estrogen receptor agonists. In fact, when given an estrogen receptor beta or alpha agonist, there was actually an increase in depressive-like endophenotypes. And how do we explain this? We explain this by using the healthy cell bias of estrogen action, which was proposed by Roberta Brinton, such that estrogens are providing a reduction in depressive-like endophenotypes under non-stress conditions, but not necessarily under stress conditions. In fact, they might be exacerbating them when you're agonizing certain estrogen receptors. So what does this suggest? Estrogens are not uniformly antidepressant, although we did see some more beneficial effects on the hippocampus, but I didn't have time to talk about it. And a loss of ovarian hormones might be just driving this depressive-like endophenotypes. This might depend on age, the magnitude of the decrease of ovarian hormones, and maybe even hormone sensitivity. And there's been some lovely work that's been done on that recently as well. The age effects makes me think of the findings on hormonal contraceptives. It looks like hormonal contraceptives might be increasing depression or depressive or antidepressant use during earlier in life if you expose them during teenage years, not so much later on in life. I just want to spend a couple of minutes talking about perinatal depression because it's a time of greatest risk to develop first-time depression. Now, it's defined as depression during gestation or up to 4 weeks postpartum. However, you can get depression onset during pregnancy or in the postpartum. And it turns out there's different risk factors. If you have it during pregnancy, you're more likely to have had a history of depression. If it occurs during the postpartum, it's more likely first time or de novo depression. Now, why might that be? Well, it turns out that it's almost like a perfect storm for depression. All of the same biomarkers we see with major depressive disorder are also seen during the postpartum period. And we created 2 animal models of postpartum depression. I'm going to briefly tell you about the second one, which is giving increased cortisol or really high levels of stress hormone during the postpartum. And in fact, in the human literature out of Alquisto's lab, they've also found at higher levels of cortisol in the postpartum with people with depressive onset during the postpartum. And what we found using this model is reductions in maternal care, increase in depressive-like endophenotypes later on, like in the forced swim test, passive coping, or reductions in neuroplasticity, particularly in the hippocampus. Now, we've given SSRIs or selective serotonin reuptake inhibitors, and we can reverse the effects on maternal care. We've never been able to reverse the effects on in the late postpartum. And we see a signature of increased inflammation during this time period. So we thought, can we reduce inflammation during this time period and then improve the efficacy of SSRIs? And in fact, that's what we seem to be showing. So this is using anakinra, which is blocking the IL-1 receptor. And this is neurogenesis. This is a measure of neuroplasticity in the hippocampus. These are animals given oil or placebo. When we give them cort, which is in this pink here, we see a reduction in this neurogenesis marker. When we give fluoxetine, that's an SSRI or Prozac, we don't see a rescue of this effect. But when we give that inflammatory blocker plus fluoxetine, we actually see a rescue of that effect. And that inflammatory signature might actually be what's driving the inefficacy of SSRIs. Now, when I gave this talk to Alquista Scalquito a few years ago, she said, it's more than just 2 variations of perinatal depression. And in her clinic, she's seen, of course, healthy individuals that have chronic depression throughout, individuals that only show depression during pregnancy, or with an early postpartum onset, or with a late postpartum onset, showing that there's a greater heterogeneity of perinatal depression than we first thought. I'd be remiss if I didn't talk about Jamie McGuire's work, which directly led to the first time the FDA approved a treatment specifically for perinatal depression, brexanolone, which is an analog of or a metabolite of progesterone, allopregnanolone, which is a metabolite of progesterone. And it works great during the postpartum, but it doesn't really work very well in premenstrual dysphoric disorder, suggesting that we also need to think about precision medicine even within women's health. A point I want to make is that I think we overgeneralize, and that overgeneralization is likely a barrier for women's health. Details really matter. We say perinatal depression like it's one thing, or estrogen, or pregnancy, or menopause, when in fact there are many of these. And when we overgeneralize, we are running into issues. That's probably because there's a lack of publications in this area. There's a lack of funding in this area, both in the US and in Canada. So hopefully I've convinced you that it's really important to look at sex-specific experiences as they can inform on depression. And my take-home messages are, it's really important, no matter what you're studying, to understand who's getting the disorder and when, because that's going to be really important for translation. To embrace that heterogeneity and complexity in your data, and to rethink dogma. If we only rely on what we've previously known, we're going to run into those atypical labels. So with that, I'd like to just acknowledge the funding agencies and the people that have funded this work and the people in the lab that do the work. Thank you very much. Oh, I also wanted to say OSSD 19th annual meeting, Albuquerque. If you can come, please come.
Well, thank you for that. And please, I'd like to note that those who are tuned in to this event live can submit questions at any time using the Q&A function, and we will try to address as many as we can during the panel discussion portion of the program. Now, please welcome Camille Wilson, who will help us to better understand the experience of navigating depression and menopause.
Sorry, I gotta come on camera. Great. Now I'll share my screen. Okay, can everybody see my slides? Can I get an audible,
Yes,
please?
yes, we can.
Great. Thank you. Thank you so much. So glad to be here with you all today, and really appreciate being able to talk about both menopause and the patient perspective in the context of depression and depressive orders. First, I want to start with a story. And I really want to talk about a senior level executive who was greatly impacted by menopause and the perimenopause transition specifically. She began experiencing symptoms at 43 years old, was completely unprepared for them. She has found herself spending several years in perimenopause. You all may be aware that perimenopause precedes menopause, which is the cessation of our menstrual cycle, 1 year of consistently not having a menstrual cycle. And that perimenopause can last up to 10 years. And she experienced a range of physical and cognitive changes while she was going through this, which actually impacted all aspects of her life, including work, causing kind of a pause in the trajectory of her career. And so, given Irene's introduction, it's probably no surprise that this is me. And you see this picture, and it looks actually markedly different than what I look like today on screen. But that's also relevant. And I'll talk a little bit about this picture that you're seeing on screen was probably taken about 5 years ago. And I have found that through my menopause transition, multi-year transition, I've experienced a range of not just cognitive and emotional changes, but also physical changes that every day I'm working to embrace. So let's get into it. Menopause is a natural biological process, right? That everyone that's born with a female reproductive system will experience. It's not a disease or a disability, but it tends to still be very widely misunderstood. And that's because I would venture to say, I do want to offer the disclaimer, I'm not a doctor, I don't play one on TV. So this all comes from the perspective of my lived experience going through perimenopause, but also spending several years as a public stakeholder and a patient stakeholder, patient advocate, particularly in the realm of women's reproductive health. And so menopause is not widely understood, certainly from a patient perspective, and that's because, as I've learned, it's not widely understood necessarily by a healthcare practitioner. community. And so there's a lot of mystery to it. Many people think mistakenly it is a disease because there are at least 34 symptoms that are commonly recognized with perimenopause and menopause transition. And they run the gamut from physical to cognitive to emotional. And of course, today we're going to talk about um, more of the emotional and the cognitive impacts of menopause. But really, I'll get into a little bit how, yes, and we heard Dr. Galea speak to it. We heard Dr. Gabelayel speak to it a little bit, that there are these peaks, particularly around the increase in where we have higher levels of reproductive hormones, that we can experience a peak in depressive orders. Some of the emotional implications of menopause are outlined here on the screen. Mood swings or irritability. If I'm going to be even more direct, feelings of rage and hostility can be marked by this transition and kind of the reduction in our sex and reproductive hormones. Feelings of sadness and depression, anxiety and nervousness, fatigue and low energy, right? And this is all due to, as we heard Dr. Galea previously speak to, the fluctuating estrogen levels impacting our neurotransmitters. But then it's also some of those other symptoms that, those 34 symptoms that are undoubtedly impacting. Sorry, I advanced too quickly. They're undoubtedly impacting the emotional experience, or the gravity of the emotional experience through menopause. So if you're experiencing anxiety, if you're experiencing fatigue, or if you're having a hot flash in real time that is really trying to throw you off your focus and your game, as I am right now. If you've gained weight, if you've noticed changes to your hair, right? Your hair is thinning, you're losing hair, your skin is drier. No matter what you do, you're always itching, right? These are things that are inevitably going to affect your emotional state, in addition to, right, those physiological changes that are happening as a result of the fluctuation of our reproductive hormones. And so, as Dr. Galea spoke to, and also Irene mentioned at the start, about a third of women experience symptoms of depression during kind of perimenopause transition. And I am certainly one of those. Increased risk factors include history of depression or mood disorders. And I do want to stick on this one here a little bit, because personally, my own experience, I am one of those who has experienced depression throughout the course of my life. I'm 51 now. I remember very viscerally experiencing bouts of sadness in my teenage years. Kind of moved through that, and was able to manage it. Felt like I settled a little bit in my 20s, and then again was hit really with anxiety and depression during postpartum, really lasting about 6 to 9 months after having my son about 20 years ago. And fortunately for me, because I'd experienced kind of the feeling power of hormones in my teen years, I recognized it then as such, as being hormonal. What's interesting is, fast forward to perimenopause, and I'm about 8 years into perimenopause. I still actively get my cycle every month. Um, is that the depression has been markedly different. It's manifested in a very different way. It hasn't been like a cogent or debilitating sadness. Rather, it's been like this low grade lethargy, lack of interest in doing things, kind of really isolating of myself, and that has been markedly different than kind of my previous bouts that I described during my puberty years and in postpartum, which that was really marked more by feelings of sadness. Uh, this stage has been more, like I said, low grade depression, lethargy, but also kind of an increase in anxiety and a different type of anxiety, largely focused on feelings of panic, doom and gloom. And again, I really appreciate the opportunity to talk with you all about this today, because as someone who's gone through depression throughout the course of my life, to get here and experience it differently, to have a different feeling of anxiety, a different feeling of depression. I really wasn't clear on what was going on with me until I started having more conversations through my menopause work with health practitioners in the space who were able to engage me in conversation that what I was describing was markedly, yes, was markedly different, but also very much corresponding to what I was experiencing with the fluctuation of my hormones going through perimenopause. And so once I heard that, once I recognized that, it took away a lot of the concern around what was going on with me and demystified it. And so I think it's just really important that we talk about these things, that both as healthcare practitioners, but also um, individuals as patients. Certainly, it's been my experience the days of the doctor patient relationship where we as patients are wholly relying on our doctors to fix us or to help us feel better. I think just with the changing nature of the healthcare system, that's changed. And so I really do advocate and take the position that patients have to be partners in their own care. And certainly that's been my experience as I've gone through perimenopause. And it really is, and it's very important. This is not about, for me at all, demonizing or casting blame on doctors or healthcare practitioners. That's not at all what it's about. It's just with so many pressures on the healthcare system, overwhelming demands on the needs of physician and the time of physicians, that patients, that we have to take some ownership and accountability in what's going on in our own health. And so that said, I do advocate that whether you're a healthcare practitioner, advocate, or champion, right, talk openly about certainly perimenopause, menopause transition, the implications of our hormones on our emotional and cognitive changes, because it's really important to normalize it. And I know that it helped me speak more openly about the anxiety I was feeling, the low feelings or the feelings of lethargy or apathy that I was experiencing with my doctors, with my friends, in community, when I was able to make that connection, that it wasn't just me, I was like weak minded or weak spirited, but there's actually a physiological, a hormonal, a biological reason why I'm going through these things. And so I think it's really it's really important that we engage, that healthcare practitioners engage their patients in these direct conversations and help them understand what's going on with them. Because there's so little known about menopause medicine, again, as those healthcare practitioners, as champions, as advocates, right? I think it behooves us all to get educated about what this period of transition is, what treatment options are available, both hormonal and non-hormonal, because while hormonal treatments can help a number of women who are going through perimenopause and menopause transition, it certainly is not appropriate for all women. So I think it's imperative to have a comprehensive approach or purview on treatment for women during this time. I myself have been taking an SSRI for the past 2 years to manage some of that panic anxiety, that doom and gloom that historically, if I have not managed, will kind of evolve into a much deeper depression. It's just part of my mix, but I also have adopted some lifestyle changes. I get out and walk my dog every day. I expose myself to fresh air. I've increased my vitamin D uptake, right? And I'm doing those things that I can while recognizing that I am, yes, going through a biological, physiological change, but I want to optimize all that I can by also making some lifestyle changes that will support me in that. Um, and this is one of the last slides, and it can't be, it's really important. I think, again, practitioner, advocate, champion, it's really important to normalize this period of a woman's life or an individual's life who's going through perimenopause, menopause transition. We have power of voice from wherever we sit, and it's important to model that and influence those networks where we can influence them. Again, I appreciate being included in forums like this, and I will always respond to the call, whether I'm going to break out in a full-fledged hot flash or not, because it's really very important that we continue to talk about this openly and that we model what it looks like and are pushing and working together for solutions. Power of position. Irene shared in my bio that I am still a senior executive at ARP, in addition to running my menopause platform. And just last week, I'm very proud to share acting as the executive sponsor for our Women's ERG and Menopause Subcommittee. We put forth a proposal for a workplace policy to support women or individuals going through perimenopause in the workplace, similar to how supports are offered for family planning, infertility, et cetera. And last, power of purpose, advocate and educate. Forums like this, making sure that this perspective of midlife, women in midlife and beyond, and making sure that we're not left out of that discussion, and really focusing and emphasizing quality of life across the health span. And so that's what I have for you today. Glad to be a part of the discussion. Thank you.
Thank you so much, Camille. We appreciate you sharing. And so, everybody that's here, we've talked about public health, we've talked about research, talked about patient perspectives. Our final panelist, Lindsay Miltenberger, will lead us in a conversation about policy solutions. Welcome, Lindsay.
Thank you so much, Irene. I really appreciate it. Good to be with you all this afternoon. My name is Lindsay Miltenberger, as Irene said, and I'm the Chief Advocacy Officer at SWHR. Next slide, please. So I admittedly toyed with what I wanted to focus on as part of this presentation today. Where I kind of landed is a quick level set, the role of science and healthcare policy, touching on that at a high level, then shifting into ways to engage in the policy process and ways that advocacy efforts might look a little bit different this year than they have in years past. But really where I decided I wanted to spend the bulk of my time was focused on the current policy and mental health landscape, because a lot of what's happening right now is fundamentally changing what we know of as the mental health and research landscape in this country. And that I think for us to be as effective advocates, in order to weigh in on options about how we can best close the depression gap, it's important to be aware of some of those changes that are taking place. And then I'll close out with just some practical tips for how you might go about advocating in today's political climate. Next slide, please. So as I mentioned, I wanted to start with a very quick level set, the role of science and healthcare policy. There is a really important partnership that happens between researchers and clinicians and public health experts and policymakers that helps us translate science into effective and actionable public policy. There's this quote over on the right-hand side of the slide that science is not finished until it is communicated. Policymakers are inundated with information on a daily basis, on an hourly basis, on a minute-by-minute basis, really. And scientists have a responsibility to elevate findings and connect the dots about what the research's public health implications are for policymakers so that we can kind of achieve this ultimate goal of evidence-based policy. The conversations that scientists and clinicians and patients take up to Capitol Hill or to members of the administration can directly influence how funding is directed. It could inform clinical practice guidelines. It could help policymakers as they are evaluating programs by determining whether or not they're working. Are they effective? If they're not working, are there ways that we can adjust these programs to make sure that they're reaching the people that need them most? If they are working effectively, how can we scale and spread and get them into additional communities who may need them? The intersection of these two is where evidence informs action. And if it provides any insight, there was a review a few years back of the 10 greatest public health achievements of the 20th century. And that review found that each of those public health achievements was influenced by policy change. So if we think about things like seatbelt laws or regulations around smoking in public places, the implementation of regulations around permissible workplace exposures, we see that policy has a tremendous bearing on health status and on health outcomes. Next slide, please. So let's take a very quick look at what this might look like in the mental health space when science and policy converge. So on the science side, we have, the research, the clinical trials, the public health surveillance, and on the, that's kind of the knowledge generation piece. The policy side is the legislation, the regulations and standards, funding decisions about how federal health programs which federal health programs are set up, information about what is communicated to the public and how. And then where the two of those meet is evidence-informed policy. And, with respect to the mental health space, I think about whenever I had my son about 9 months ago, whenever I went into follow-up appointments with my OB/GYN, whenever I took my son to his pediatrician appointments right after he was born, I was getting screenings and questionnaires about my mental health. And that's a great example of how things that we have learned on the research side can be implemented in practice. From research, we know about the risks of perinatal depression and that many maternal health disorders go undiagnosed, and screening can be a really helpful tool. So that's just one example of how this might come into play in reality. Next slide, please. So I won't spend too much time on these, but these are some of the ways that members of the public can engage in the policymaking process throughout the year. Communication with policymakers being especially key. I would also note that based on the discussions that SWHR has been having with different policymakers, with our colleagues in the policy and advocacy space right now. While coming to DC is helpful, and I would never discourage that, I think the most influential discussions that are happening right now are happening in the states. So if your lawmakers are doing town halls, attend them, request meetings with local offices. I would say the state advocacy is even more important right now than it has been in the past. So that's a little bit of a shift in terms of how I might advise people to get involved in politics. I would also say don't overlook the power of op-eds, opinion editorials, or letters to the editor in local news publications, because members' offices often pay attention to those to make sure that they have a pulse on what's happening in their state or in their district. And those tools can be really effective for getting the ear of somebody in the member's office and elevating an issue that is really important to you, especially if you know that this issue is already getting play in the national media. And then, of course, there are other things, action alerts, getting involved with coalitions, making sure you're staying up to date with what your professional societies are doing. Are they doing member fly-in days that you could participate in? Are there sign-on letters that are accepting individual signatures that you might sign on to? Are there campaigns going on where you might lend your voice and help elevate an issue? But the other thing I would say is just really building connections with policymakers' offices, even if there isn't something, a specific ask you have right now, laying that foundation early on, sharing who you are, your expertise, what you work on, and just kind of laying that foundation, building that relationship can be important so that when something does roll around that you want to engage on, you already have that relationship and that rapport with congressional staff, and it might give you a better platform for engaging in some of those conversations. Next slide, please. On the regulatory side, there are going to be some changes this year in what I would typically advocate, which I will get into later. But I would still say that it can be helpful to provide feedback and to try to engage with the administration on things that could have a bearing on the nation's regulatory agencies. So one example I have listed here that I don't think is often thought about from an advocate perspective is the Office of Management and Budget. The Office of Management and Budget, and I know this from conversations that we have had with members of their team, are always looking for information about how well different federal programs that the government is funding are working and if there's anything that can be improved. So finding the right contact within OMB and reaching out to them could be a great way to advocate for the programs that you care about and to demonstrate their impact on a broader scale, kind of really providing the lessons learned, the knowledge that has been gleaned from those programs could be really helpful. I don't know about the status of public meetings. And like I said, I'll go into this a little bit later. But historically, federal agencies have hosted kind of public meetings throughout the year, whether it's allowing people to weigh in on drug pricing issues or things like that. And sometimes within those opportunities, there are opportunities for people to provide public comment. You can apply to have 5 minutes within that meeting to make your case. And so keeping an eye out for opportunities like that is another tool that you have at your disposal. Next slide, please. But like I said, where I really wanted to spend the bulk of our time today is just looking at the current policy landscape, because like I said, there's so much happening at the federal level that actually sounds like an understatement. But like I said, I think in order for us to be effective advocates, we need to know about what's going on and what changes are being made and where the new touch points might be and what the new areas of interest for the new Congress and the new administration are, so that you can figure out how you might want to frame an argument or tie your message into some broader initiative. So there have been many developments over the past few months, many of which we are still trying to interpret or obtain additional information on. And of course, I would say for a lot of this, we may not even know all of the ripple effects until weeks or months or years from now. It's been really important for SWHR as an organization to be very measured about what we are reacting to, because we hear new rumors what feels like every week. And we want to make sure that the ways we're engaging and the information that we are sharing has either been released by the administration or confirmed by congressional staff or other trusted partners that we have. So, and again, this is just a snapshot of all the things happening. There's no way we could spend all the time today going through everything that's happened, but relevant for this discussion and some things that could have a bearing on the mental health policy landscape at the federal level. In late March, the U.S. Department of Health and Human Services announced that it would be restructuring in accordance with the president's executive order, which was called Implementing the President's Department of Government Efficiency Workforce Initiative. So notably, as part of this restructuring, the 28 divisions within the Department of Health and Human Services will be consolidated into 15. That includes a new, what they're calling an Administration for a Healthy America, which combines multiple agencies, including the Substance Abuse and Mental Health Services Administration and the Health Services and Resources Administration, among others. Another part of that restructuring is there will be a new Office of Strategy, which will combine the current Assistant Secretary for Planning and Evaluation and the Agency for Healthcare Research and Quality. Beyond that, the announcement from HHS also noted that there would be a reduction in workforce across HHS between this and a few other administration initiatives that would reduce the workforce from 82,000 full-time employees to 62,000 full-time employees. Another update that is pertinent to our discussion and related to engaging in advocacy and the regulatory process, and this is when I mentioned earlier that the regulatory advocacy opportunities were going to be a little bit different this year. This is what I was referring to, which is that on March 3rd, HHS made an announcement via the U.S. Federal Register that it was going to be rescinding a policy on public participation in rulemaking. So for those of you who have gone through this process, historically, whenever agencies are undergoing a strategic planning initiative, creating a strategic plan, or releasing a new proposed rule, they will release opportunities in the Federal Register for members of the public to provide comments on the guidance, whatever it is, and elevate different things that the administration may want to consider as they're crafting that final rule. What happened here is that the administration removed a policy that was known as the Richardson waiver, and the Richardson waiver required that voluntary public notice and comment periods for regulations that didn't fall under a bill known as the Administrative Procedure Act could involve members of the public. So HHS rescinded that waiver. It is our expectation that some notice and comment opportunities will continue despite this policy decision because they do fall under that Administrative Procedure Act. So it's my understanding that common opportunities that are related to things like Medicare and Medicaid will still undergo the public participation in rulemaking, but I would expect that a lot of health-related matters would be affected by this rule. So anything pertaining to federal research, I would expect to be affected. That is not going to stop SWHR from weighing in on administration policy, but it does remove that formal mechanism for the public to provide feedback. So I think that's an important change for people to be aware of. And then looking within the HHS infrastructure, we've also heard about a lot of things happening within the National Institutes of Health, or NIH. So most notably, NIH has terminated numerous research grants, saying that the research projects no longer effectuate agency priorities. As of late March, an NIH official had said that more than 900 grants had been terminated. But I think this is an area where much remains to be seen. There are tools in place for grant recipients to ask the agency's director for a review of the decision in an attempt to appeal them. Litigation is already in the works. There was a lawsuit filed in early April. But again, going back to advocacy, SWHR has had many conversations with members of Congress, and they are looking for specific examples of research grants that have been terminated. So if you are in a position to share that information, or you are willing to work with the professional societies that you are involved with, I think that's one of the most helpful things that you can do right now, is because members of Congress, I don't think, I think they're trying to get a sense of the scale of the impact and what exactly has gotten caught up in these funding termination decisions. I can tell you that we on the SWHR side are trying to figure out which women's health grants have been affected. There was a list of grants on the HHS tags website, a list of grants that had been terminated, but we have heard some questions about the accuracy of that report. So we have not taken that as final. It's most helpful for us to hear from stakeholders in the community about what's been impacted. So that is one venue for advocacy that I think is really, really relevant right now. Another notable update from the administration over the past few months was the establishment of the Make America Healthy Again, or the MAHA Commission, which will be chaired by Secretary Kennedy. There was a lot of focus within this executive order about the need to understand and drastically lower chronic disease rates. And there was a big focus on ending childhood chronic diseases. But the executive order also mentioned combating rising rates of mental health disorders, obesity, diabetes, and a few other things. Autoimmune diseases and conditions, I believe, were also mentioned specifically. So as part of that executive order, the administration has requested that within 100 days, the commission is required to submit an assessment to the president, and within 180 days to submit a strategy based on findings from the assessment about their recommendations for how the federal government's response might be restructured to address chronic disease in this country. So as you are thinking about your own work, anything that could tie back to some of these priorities that were outlined in the Make America Healthy Again Commission's executive order, and showing how your work is relevant to those priorities could be another helpful strategy for engaging right now. And then the last kind of high level thing I'll touch on here is, of course, the federal budget and appropriations process is still incredibly relevant and will have a major bearing on the future of health research on mental health in this country. So the president is expected to release his budget in early May. And this usually, I don't know if I can say usually anymore. This is supposed to happen in February each year. It always comes later in a presidential transition year. But this is a document that's one of the first parts of the regular appropriation cycle each year. The president releases the budget outlining his administration's priorities and how he envisions the funding infrastructure to look for the upcoming fiscal year. It is important to note that the president's budget is just, it does not carry the weight of law. Congress still holds the power of the purse, but the president's budget is an important signaling document. And so, last month, and you may have seen some news about this, there was a leaked budget passback document that in theory is part of the president's budget that has yet to be released. But within that budget passback document, the administration had outlined its plans to cut nearly a third in discretionary spending from the Department of Health and Human Services. Now, because it was a leaked document, that is, of course, subject to change. It'll be interesting to see whether or not there have been changes between the initial document and the official document that's released from the administration. But there were things in that budget passback that raised some concerns for federal research. So one of the things that was called out was reducing the budget of the National Institutes of Health from 47 billion to 27 billion and consolidating NIH's 27 institutes and centers into 8. So more remains to be seen there. Next slide. And I know I'm out of or over time, so I'll wrap this up really quickly. With respect to the mental health landscape, I spoke about most of this in the previous slide, but I think the big point here is a lot remains to be seen in how the administration is going to work to combat mental health within this new HHS infrastructure. And given the workforce reductions and the moves to reduce funding, the administration has said it wants to combat rising rates of mental health, but what does that look like on the ground? So again, we're watching and we'll keep an eye out there. And then last slide. So knowing about ways to engage in the process and what's happening at the federal level, what are some practical tools that scientists and clinicians can use as they're engaging with policymakers? There is a body of research in political psychology that looks at how partisan identity is now really tied to social identity. So it's become so central that often if you are seen as attacking political beliefs for that other person, it will feel like a personal attack. So for advocating with policymakers, especially those who hold different views, it can be helpful to use some of these strategies to potentially overcome any resistances. First is building trust and credibility. First, people are more open to persuasion from sources they trust. Using framing that aligns with their values. If you can reframe your argument to match the policymakers that you're speaking with, moral values or policy priorities, that can be really helpful. Ask open-ended questions. Motivational interview techniques is about asking open-ended questions, reflecting policymakers' concern, allowing them to articulate their own reasons for change. That's a tool that can really reduce resistance. So even starting a conversation with, what do you know about XYZ? Stories are always one of the most effective tools that you can use. Consider who the messenger is. Can you share your message with, or have a respected member within the policymaker's own party to share your message and carry that torch forward? There can be a way to highlight inconsistencies in a policymaker's values, but you need to do that very carefully. And to do that, I would say affirm core values before, before trying to thread that needle. And then, that's similar to the last thing. Affirm provides affirmation for their beliefs before entering into any challenges. So I know I'm over time. I'm sorry. I'll stop there. But thank you all for having me.
Thank you all for rousing these presentations, to be able to tackle from all these different angles how depression affects women and women's health and how we can address them. And so I invite all our panelists to turn their cameras on at this time. And I know because we are short for time, we won't be able to get into any Q&A, but we have a wrap-up question that I always like to ask. And so I think in a way we might be able to touch on some of that Q&A. So we have diverse audiences that span patients and healthcare providers, as well as researchers and policy professionals that tune into our events. And so I'm going to ask each one of you to share your suggestion for a solution. It can be low-hanging fruit, or it can be a long-term strategy that can address research, healthcare, public health stigma for women living with depression. And so I'm going to mix it up a bit. So we'll start with Lindsay. And Lindsay, can you speak to the research community specifically? Camille, then I'll have you go, and can you speak to healthcare providers? What you think they would be able to do? Nitsan, can you speak to the women that are watching out here? And then Lisa, we will end with you speaking to the policy community.
So I think my takeaway message for researchers is don't underestimate the power of your voice. You are incredibly effective messengers. The work that you are doing is some of the best to explain the public health implications or to inform evidence-based policy. I think evidence-based policy is our gold standard. So making sure that we are creating tools to have research inform what is ultimately going into policy and practice is what we should be striving for. So use your voice.
For healthcare practitioners, healthcare community, I would say listen and acknowledge your patient experiences. Right, think of them as a partner in their care. And also, I think it's helpful and it's a better a patient experience, even though if you're not rooted in menopause medicine, really understanding the implications of that period of life, right? 35 to 55, and kind of all that's going on there, and that the women might not be experiencing depression and isolation, but within the context of their perimenopause transition. And I would again be partners to your patients, educate yourselves on resources and information that might be helpful to them. And just empower them, right? Listen, empower them, educate yourselves so that you can better serve women in this period of life.
Yeah. I'll just go ahead and say for the women watching, I think just don't underestimate what you're feeling. What you're feeling is valid. And if you suspect you're suffering from some type of depressive symptom, don't underestimate it. Go and speak to your healthcare provider. And if you feel like your concerns aren't being answered, switch healthcare providers. You deserve to be listened to. And I think that's the main message. You deserve to be listened to and that your concerns will be met. I think that's the biggest message for me, at least.
Yeah, did you want me to give one too, Irene?
Yes, to the policy community.
To the policy community, I would say, I mean, I think all of the major points have been really touched upon. Don't, I think one of the messages I had was don't overgeneralize, and don't, you've got to be your biggest advocate. That's going to be true for your health and for the health of women. I think in my bio, it says something about like she's a tireless advocate for women's health, but like I'm getting tired. I have to say, like, no, like it's tiresome out there. There's a lot of dogma that's not really rooted in science. And so you've got to advocate for yourself and share that there's not a lot of dedicated research on women's health factors. And just because something might work for a TikToker or an Instagram influencer doesn't mean it's going to work for you. So just really be careful of the resources that are out there too. It might work for you, and that will be great, but keep track of your own health.
Thank you so much. These are all great points of advice. We thank you for being such an amazing panel, for your presentations, providing your time and your insight. Mental health is one that touches every home in one way or another, and every community. And so we also thank Virginia Commonwealth University for their support of this Emerging Topics in Women's Health Symposium. Thank you again. SWHR will continue the conversation. SWHR talks mental health in our work to promote research to better understand, diagnose, and treat depressive disorders in women. A call to action that Dr. Gable Ayel discussed earlier, illuminating the disease burden of chronic forms of depression in women, can be downloaded from SWHR's website, www.swhr.org. We also have policy agendas, webinars like this, blogs, and other resources about mental health and its intersection with other health conditions that disproportionately affect women and women's health. There were some additional questions we weren't able to get to about intersection with like thyroid disease, with sleep health, with metabolism and weight gain, and of course, these different hormone transitions. We are going to continue to engage those conversations. And so as you have them, continue to reach out to us on social. And with that, I would even say that, understanding women's individual experiences and health journeys help us inform providers and policy decision makers on critical gaps in women's health. SWHR invites you to share your story about depression, menopause, maternal health, and other women's health topics by visiting www.swhr.org/share-your-story. And again, connect with us on our website as well as on social media to download women's health resources, register for future events, and sign up for our newsletter. We will be sending out an email with the recording of today's symposium to all the registrants, as well as post a recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue, again, this very important conversation with hashtag SWHR Talks Mental Health. Thank you for joining us.